Dear colleague, welcome to this PCR webinar entitled How Should We Treat a Patient with High Bleeding Risk Requiring Complex Distal Left Main PCI for ACS. This webinar is supported by Medtronic, and for this webinar, I have the pleasure and the privilege to have a great team with me today with Alaide Chieffo from Italy, Bernard Chevalier from France, and Emanuele Barbato from Belgium. So during this next 60 minutes, the objective of the webinar is to first review the existing evidence on the management of high bleeding risk patients treated with PCI, to reflect on the complex PCI strategy in high bleeding risk patients, and also to share tips and tricks for the treatment of distal left main with PCI. So the format of this webinar will be first to have a short update on the existing evidence for complex PCI in HBR patient in 2021. And after, the main part of the webinar will be case-based with a beautiful recorded case recorded in Massy, thanks to Bernard and his team, and commented by Marco Vailgimigli and myself during the recording. So without further introduction, it's my pleasure to introduce and to ask Alaide Chieffo to give us a short update on the existing evidence for these challenging patients. Alaide?
So thanks, Thomas, and it's a pleasure for me to be on this PCR webinar with friends such as Bernard and Emanuele, and it's a pleasure for me to introduce you this very interesting and hot topic nowadays in our subspecialty. Let's first start on which are these patients. So what are we talking about? Who are the high bleeding risk patients? And despite some discussion initially when it was pointed out the issue of PCI and the issue of dual antiplatelet therapy and duration in this patient, 2 years ago, it was published kind of simultaneous in European Journal Circulation, the ARC-HBR criteria. The ARC-HBR criteria are taking into account the comorbidities and factor of the patient that are associated with a high bleeding risk that are listed and illustrated in this very nice slide courtesy of Davide Capodanno. And as you can see, according to the ARC-HBR criteria, you can define a patient as HBR when they have one major criterion in dark blue or two minor criteria. Recently, it was also published a very interesting study that was taking into account a trade-off model derived using pooled patient-level data from 5 randomized clinical trials and 1 observational registry of HBR patients with external validation of the Onyx-1 trial. And this was just pointing out that the risk of death after MI and stent thrombosis is much higher than the risk of death after BARC type 3 to 5 bleeding. They developed also a risk score model that you can even download in your with an app in your iPhone that help you in defining this patient and giving a score to this patient, helping you then your decision making during PCI. As we said, this is a very interesting patient population because it's a patient population that at the same time usually, as we have seen from the definition, are patients that have high ischemic burden together with the high risk of bleeding. So are patients where it is important to test the right stent and to associate this with a lower duration of dual antiplatelet therapy. In these slides are illustrated all the device trials that have been published and conducted so far. The one that were randomizing using a DS as a control, like the Onyx-1, the one that randomized using a BMS as control, and the one non-randomized that use historical cohort or OPG as a control. But we are also introducing the combination of both that quite frequently are in our real world CalLab activity, the complex PCI, which is a complex PCI. Just a reminder, this was a work that we did in 2016, coming up with the definition. PCI with one or more than one of the following characteristics is a 3-vessel disease patient, more than 3 lesions treated, total cell length more than 60, bifurcation with 2 stents, use of atherectomy, left main, CABG, and CTO. And in these slides, it is showed a sub-analysis that was run from the Onyx 1 clear data. They split it in complex PCI and non-complex PCI in the setting of eye bleeding risk and evaluate the patient at 1 year. As you can see, complex PCI is illustrated in orange and non-complex PCI illustrated in green, and both were at eye bleeding risk. And these were the criteria in the eye bleeding risk definition that were encountered in the two groups. Clearly, elderly age was more frequently encountered in non-complex PCIs, complex PCI that indeed were patient in anticoagulant and with more comorbidities and complex anatomies. And in fact, again, from the same sub-analysis from the Onyx 1 clear, these are the components that were defined in the complex PCI in this cohort of patients. Mostly, this was a total stent length more than 60, followed by all the others. And in this specific sub-analysis, only 4.7% were patients with left main. So the left main, complex left main in eye bleeding risk is not very well represented. And procedural characteristics, as you can expect, these are patients, the complex PCI with eye bleeding risk with more complex anatomy, less usage of radial access, more usage of atherectomy, and unfortunately, still, at least in this experience, intracoronary imaging was very low, 20% in complex PCI, and we all know that we should aim with higher guidance with IVUS. And all the number of vessel, lesion, or stent were higher in the complex PCI patient. Clinical outcome, despite numerically and at an unadjusted analysis, the complex PCI with eye bleeding risk had more events, indeed, when they adjusted the analysis, because mostly of numbers, this difference was not statistically significant. Then it's all about the balance between, as we said, ischemic events and bleeding events. And what we can advise in case of eye bleeding risk and complex PCI. Clearly, what we advise in our everyday practice, the importance of functional testing and intravascular imaging guidance. Why that? Because physiology is key to decide your revascularization strategy, to really guide and avoid the usage of more stent than needed. That it was something that we were done before the physiology and functional guidance. So you can plan your PCI approach in this sense. Importance of imaging, despite the rate of IVUS imaging that was done, for example, in the Onyx Clear analysis data, indeed, we should aim for more IVUS imaging, because clearly, if you guide your procedure in the left main with IVUS, we do know that this is going to be correlated with lower events. Lower events meaning less stent thrombosis and less death. It can be used also for your imaging to plan calcium treatment strategy, and also to lower the amount of contrast you're going to go in this patient, because as we see, eye bleeding risk in very high frequency, they have also clinical disease. And this is just an algorithm by Emanuele just explaining you the importance of imaging, because according to the imaging and the presence of calcium, you have to use the right tools that can go just from non-atherectomy strategy when there is mild calcium in the coronaries. Indeed, when the calcium is more than 270, you have to use devices as rotablator or orbital atherectomy in order to have a good stent expansion. And again, we are talking about complex left main PCI in high bleeding risk, the importance in deciding your stenting strategy ahead, because the approach is dictated by the side branch. Just to mention the ABC. ABC was a randomized clinical trial that was conducted from the European Bifurcation Club with an unrestricted grant by Medtronic, and the study was evaluating the provisional approach, which is a step-by-step layered technique according to ABC consensus with POT mandated and KISS mandated versus a systematic two-stent approach according to operator choice between TT, TAP, culotte, and AK crush. Again, with a step-by-step approach, aiming to have high pressure ostial bifurcation dilatation, kissing, and final POT. And these are the result of the study. That the primary endpoint of the study, that MI TLR, was 14.7% versus 17.7%, aiming that it is, according to the study, advised to have a stepwise provisional stenting, which does not mean only one stent, but evaluate after one stent if really you need to have two stent or you keep with one stent. Just to mention, only 20% of the patient had to switch from stepwise provisional to systemic dual stenting. In conclusion, in high bleeding risk complex PCI, you have to evaluate the trade-off between bleeding versus thrombosis. New generation DES has proven to be safe and effective in high bleeding risk, and then plan your procedure carefully, especially in the setting of high bleeding risk left main PCI, with functional and intracoronary imaging guidance, careful lesion preparation, decide and use the right stent, and then decide your stenting technique according to side branch.
Yeah, thanks a lot, Aleida. I think it's a perfect introduction to see now. And again, really, please post question, but I'm sure it will be even more easier to interact during the case. So I think now we can really move to daily practice, and to go, I will just briefly present the case, and after we will move to the cath lab in Massy, and to see how we can integrate all the evidence you present into our daily practice decision. So the patient that we will discuss together today, it's a male, 76 years old, and it's a diabetic patient with high blood pressure. He is not smoker anymore. He has hyperlipidemia, and he has significant comorbidities with CKD and hemodialysis, and also COPD. So it's really a challenging patient. And he has also a significant prior medical history in terms of coronary artery disease, with in 2018 elective PCI of the LAD, the first marginal and the right, with drug-eluting stents. And 6 months later, he was admitted again for a non-STEMI with in-stent occlusion of the marginal, in-stent restenosis of the proximal right, and the new de novo lesion of the distal one. So he was treated with drug-eluting balloon and DES as well in November 2018. And he has been admitted again in Massy for shortness of breath for several months during exercise, which could be coded as class 3. So as you can see on the lab result, of course, he has a significant renal dysfunction because this patient has a hemodialysis, and also he has anemia, and we know, as we heard, that it's also an important HBR criteria. So on the echo, he has good LV function, no significant valvular disease, but on MRI, he has a clear and severe ischemia on the inferior and the lateral wall as well in 6 out of 17 segments. So of course, this patient was then referred to the cath lab, and as you can see on this left coronary system angio, patient has a tight and complex lesion of the distal left main with, on the left view, probably involvement of the ostium of both the LAD and the circ. And as you can see on the cranial view on the slide, we had also a mild lesion on the LAD. And the spider view here is not ideal, let's say, to identify the lesion of the distal left main. And on top of that, you can see, remember that this patient had already a multiple PCI of the right, and he has a significant lesion now on the ostium of the right coronary artery with, let's say, diffuse moderate restenosis in the proximal and the mid part of the right. So here, just to briefly summarize the different scores, we can say that you're looking at the Santac score 2 and the 4 years mortality. It's a really challenging patient because the mortality, expected mortality for both PCI and CABG are really high. So of course, that's a type of patient which is challenging for both us, but also for the surgeon. So on the next here, you can see a summary of the case. It's an elderly patient, but 76 is not that old. It's a diabetic patient with significant comorbidities and clearly complex anatomy with distal left main, ostium of the right. On top of that, he has also a mid-LAD intermediate lesion. So here is the case that we would like to discuss before going to Massy and see how Bernard and his team manage this patient. Probably I will ask the first question to you, Emanuele. We have a highly complex patient in terms of anatomy, but it's also a very challenging patient, as we know, for the surgeon. So what is your view for this patient? Should we present this patient to the EARTH team, or we can just proceed and do PCI upfront?
Thank you, Thomas. Indeed, this is a challenging case. One of those who would escape classic randomized clinical trials enrollment. He has many features for high bleeding risk, as it was nicely listed by Alaide. I counted many of those that were on the slide of Alaide. So, and I took notes while you were speaking. This is 76 years old. You said it's not that old, but still might be an age of concern for cardiac surgeons in some instances. And yes, COPD. So these two features would be more in favor, in my opinion, for percutaneous coronary intervention. On the other side, this patient is diabetic, and that would be more in favor for CABG. And last but not least, this patient is in dialysis. Now, we know that short-term mortality is higher with CABG, but lower with PCI, and the other way around for long-term mortality. So you see, it's extremely complex. And in addition, what makes, in my opinion, tilting the balance towards PCI, and that is what I would propose to the heart team if it was in my center, is the fact that these patients 3 years ago already had 3-vessel disease. And 3 years ago, the operators decided to treat this patient with PCI. So it's a patient with non-CAD, already with 3-vessel disease 3 years ago, and at that time, it was already decided to treat these patients with PCI. So to me, there is a clear indication to go on again with PCI in this case, but I would still defend this position within a heart team vis-a-vis cardiac surgeons.
Okay, so it's worth discussing, but it will be probably PCI. And just coming to the PCI strategy itself, Alaide, we've seen that this patient has a, let's say, complex and tight distal left main, and on top of that, we have a tight lesion of the ostium of the right. And what will be the sequences in your practice? First the right or first the left main for this specific patient?
I mean, for this specific patient, I would go first with the left main. I mean, I know this is very discussed. Someone can say start with the right, because if you have any issue with the left main, at least you have the right done. But I think it's quite critical. Normally, my criterion is if it's such severe left main, I do prefer to start with the left main. And then we can discuss if this patient is needing any support, hemodynamic support, because considering the tight lesion on the distal left main and the tight lesion on the RCA, I know it's 76, but maybe can be an indication for MCS. And if it is an indication for MCS and the femoral access is suitable, I would go with a short-term PVAD.
Okay, so in spite of good LV function, as we've seen on the echo, it could be. Bernard, it's good that we have a question from Dr. Araya, also asking about the management of the occlusion of the stent in the marginal. The plan was also to treat that or to focus on the left main and the right?
No, the plan was to skip this lesion. I think clearly the target lesion here at the ostium of the right on the left main itself. And we think that the distal runoff of this marginal was not large enough to consider intervention at this level.
Okay, thank you, Bernard. And so if we say that following the comment from Emanuele Alaide, so we can say that in this very challenging and probably frail patient, we agree that PCI is probably a good option. After to do first the right or for the left main can be probably discussed. But just before going in Massy to see how did you organize things, what will be the setup, Bernard, for your management of this left main in terms of access, guiding and imaging or not? Could you just mention on that, yes. And after we go to the cath lab.
So our practice is this patient, because it's a patient on dialysis, to use a radial approach. We use a contralateral radial approach because we think that we reduce the risk of vascular complication using radial approach versus femoral approach. And we use 6 French or 7 French, depending on the size of the left main, on if it's a bifurcation or not. And in that case, we did the right first, just to secure the intervention.
Okay, and you will do imaging in this case? We'll see that during the live.
Sure. I think it's a calcified lesion. You can see that the proximal LAD is a bit aneurysmal, so I think it's a good indication of imaging to be sure that we have a good sizing and to have a good apposition at the end of the intervention.
Yeah, and with dialysis, we do not have to save contrast. So it means that we can do a CT or FDI even without concern about the renal function, probably.
Yeah, that's right. Yeah. Patient has no residual diuresis, so there is no reason to spare contrast in this situation.
Okay, it's great. So I think now it's time to go in Massy and to see the first part of the live. And again, please really post your question and comment. We will address that together during each stop point. Let's go to the cath lab.
We have been in the left main with the 7 French EBU-4, 0, and prior to the live, we have wired the LAD and the circumflex with run-through coronary wires, and this is the first injection we had. So you can clearly see that the lesion is involving both the left main, but also the ostium of LAD and the ostium of the circumflex. So this is the view we have in a caudal view. And well, yes, for sure, this is a 111 lesion. The left main is quite huge. The proximal LAD has some aneurysm, so it should be, we measured around 4 millimeters for the proximal LAD. The circumflex is around 2.5, and with the Murray law and all the law we have to assess the size of the left main, it should be a 5 or 5.5 diameter left main at the end of the procedure.
Okay, we have wired the 2 vessels, LAD and circ, and I think it's now time to predilate because you can see that this lesion is very tight. And the flow was not totally perfect. Our initial plan was to perform the OFDI as a first step, but we think that we need to predilate this lesion with a 3-5 balloon. It's a 3-5 Ure by 15. In order to improve flow in the LAD.
Bernard, Philippe, while you're working, let me kick off with one question. Based on the angiogram that we saw before going live, actually the stenosis at the ostium of the circumflex looked much less tight. Now, perhaps because of the wire already in place, this vessel straight a bit, and now the stenosis seems to be really very tight. So actually, I do agree with you that before OFDI, probably I would try to stabilize the lesion.
Absolutely. So we plan to start, with the OFDI, but as you can see, the lesion is really tight. We had a drop in pressure now, and we thought it's much safer to predilate and have a better flow in both branches. Okay, so we were at 12 atmospheres with the 3.5 balloon. We can assess the result after the predilatation.
And Bernard, you will do FDI left main LAD, or you will also try to check, because without predilatation, it will be challenging probably to go into the circ to assess also.
No, we are not planning to do OFDI from left main to CX. I think our main concern is to assess the diameters, the length of the lesion by OFDI. We want also to be to have some evaluation of the mid-LAD lesion. But I think, considering the distal runoff of this circ, I think is no target for doing OFDI in this direction, at least as a first step. You can see that the pressure, which was a little bit low after wire placement, is much better now. So it was important to predilate towards the LAD. I think we have done now the OFDI run.
Can you see the OFDI?
Yeah, very well.
So maybe I can show the...
We cannot
hear you.
Oh, no, Dr. Nomoto. Yes, now it's okay. Please go ahead, Yoshi.
Yes, yeah. Sorry, this is the pullback from the mid-LAD, so I can just show the a little bit slowly the entire pullback. It starts from distal part, and it's diffusely diseased coronary artery. You can see that some calcification or the mainly fibrous plaque. There is one side branch coming, which is probably diagonal. There was a shorter stent, previous stent. It looks very short. I think it's probably 8 millimeter. I can make a measurement later. And then there is the area that was free from the stent again. And we are still in the stented segment. You could see the stent opens very well. Here is no stent. You see the calcification, 180 degree. Although it's not really entire, there's a two chunk of calcium. And there's another side branch coming. It's very huge coronary artery already in the proximal part of the LAD. You can probably see that probably it's already 4 millimeter. I think there was a dissection probably caused by the predilation. The tissue is more or less fibrous. We don't see too much calcification. Here we see some chunk of the calcium. And then here you see the other wire, so it's still, yeah, thank you. So it's also a very large vessel. I think it's 5 millimeter in the left main. So maybe I can change. So yeah, if you look at the proximal part of the left main, it's almost out of the range of the scanning, but it's almost 5 millimeter in the proximal part. And so you see here, this is the circumflex ostium. So circumflex ostium is very much tightened. Yeah. And you see the wire from the circumflex is coming. So I think the opening of the side branch of the circumflex is very, very small. We can make one measurement. It's almost like, yeah, it's less than 1 millimeter. So it's very tight stenosis. We can make a measurement for the length of the stent. For example, if you take this one proximal and distally little bit proximal to the previous stent, or if you try to cover until the previous stent, it will be 20 to 23. You can take landing zone around here, which is already 4.6. If you try to do that just proximal LAD to proximal left main, I think that both diameter was 5.0, 5.0. So length is, if you have an 18, probably will cover the entire part of this focal stenosis.
Yeah, that's what we planned to pick. It was a 4x18.
Okay, so during this first part, we've seen the diagnostic part with the angio and, of course, the important information provided by the intracoronary imaging just to size the stent and to plan the PCI strategy. But for this distal left main, which is, I think on this picture, clearly a 111 lesion, even if the lesion in the side is quite short, Alaide, what will be your strategy up front, meaning in terms of 1 or 2 stent, and if 2, which you think will be suitable for this specific anatomy?
I think that after the ABC main result, we should start with the provisional stepwise approach, which does not mean one stent all to cure. I mean, start with one stent implantation left main toward the LAD, then do pot, then recross the 6, do kissing and evaluate. I mean, if there is dissection or reduction of TIMI flow, or, I mean, this is according to the threshold of the operator, but I would say like that. You say like this. I mean, if you have, then you can always switch to stent, like TIM protrusion. But otherwise, I would go with the stepwise provisional approach. I think this is coming from the randomized clinical trial.
Okay, and Emanuele, maybe following that, we've seen the result of the EBC main, as Alaide said, promoting probably the first provisional, but will that really change your practice, Emanuele? And do you think we have to start always, or in large majority of cases, with provisional, or we can start upfront with 2 stents in many cases?
Thomas, let's be practical and getting inspiration from this specific case. That's not just a left main bifurcation stenosis. It's a left main stenosis within the context of a high-risk patients with high bleeding risk. So the motto in my practice would be keep it as simple as possible, because the more you make this procedure complicated, the more metal you will need, the more stents you will need, the higher the likelihood that you will need a prolonged dual interpolator therapy. So if we keep this in mind, we have now good support from an important trial, the EBC main trial, that what we used to do before having these evidences, for example, keeping simple our PCI in this specific setting, is now supported by data. So we know, as Alaide was mentioning, that if we start treating what we think it is the main vessel, so left main to the LAD, OCT was very instrumental in this case, showing a nice mismatch in diameter between circumflex and left main, and while LAD is more or less along the same line. So standing from left main to LAD, kissing towards the circ, and if there is no good reason to implant the second stent, I would leave it like this, because I know that after 1 year, the incidence of MACE will not be any better as compared to a systematic dual stenting strategy. And only if I have suboptimal flow towards the circ or important plaque shift, then perhaps I would implant the second stent. If not, I would stay away from that.
Yeah, it's Emanuele. We had also a nice comment from one of our colleagues saying that we have to do everything to avoid 2 stents in HBR patients, because exactly as you said, more stents, and it will be challenging. Maybe Bernard, we had a nice question from Dr. Zahan, saying that your patient is more or less a high ischemic risk patient because it's almost ACS and he has multiple prior PCI, but also is high bleeding risk. And the question is to know whether you have a specific device to choice in terms of drug-eluting stent in this specific HBR population, looking at the evidence described by Alaide. in your practice, Bernard?
I think what is important here is to select a device which has a good track record in HBR patient, and clearly the Onyx One study was a good indication for that. We need also to select a device which is fully compatible with this kind of bifurcation, with easy access to side branch and good behavior in case of POT on kissing, because we have here clearly to overexpand the proximal part of the stent in the left main.
Yeah, and next question also, Bernard, it's a very practical one, and I would like also to see Emmanuel and Alaide view it. Do we have to do imaging for all left main PCI? I know it's a bit provocative question, but it's practical one, so it's nice to try to give clear answer.
I think it's depending on the complexity. Clearly, here we are not here in a simple lesion. I think we have a lot of experience in relatively simple left main. I don't know if I can say that. We maybe skip intravascular imaging, partly using stent enhancement technique, which is a kind of poor substitute, but interesting anyway. But clearly, when we are dealing with this complex type of lesion, 111 Medina, when we're discussing one stent versus two stent, we should consider to use intravascular imaging.
Yeah, Emmanuel?
Yes, why not to use intravascular imaging in this complex patient? Also because they will have a very practical impact on our procedural strategy. Look what we learned in this case. We learned that after all, there's not much calcium. So that's for me an important information, that I do not need to apply unnecessary aggressive plaque modification here. So it's another good argument to keep it simple, because I don't need that. In addition, I know what is the exact landing zone of my stent in terms of size, and I learned that the previous stent implanted in the LAD, it was already evident angiographically, but at the OCT or at the OFDI, the stent had minimal proliferation. So it means that if I implant drug-eluting stent, a good DES, in a large vessel, most likely it will end up in a good result at the long term, which is not the case as compared to small vessel. And we saw that the small marginal branch got occluded. But at least in the LAD, the stent had a good outcome.
Yeah, thank you, Emmanuel. Alaide, maybe you want to comment also on that?
Yeah, I mean, let's say in eye bleeding risk, because we are talking in a left main, in eye bleeding risk, I think imaging is, let's say, is strongly indicated because you have the two problems, the problem of left main bifurcation, and then you have the problem of eye bleeding risk. In eye bleeding risk, since you are going to stop the dual antiplatelet therapy before, you have really to be sure about the result of your stenting in the left main. So this combination, left main and eye bleeding risk, I think is the combination that need imaging for a series of reasons, to see the calcium, to see how you have to prepare the lesion, to see which stent strategy you have to do, and then to test finally if the result is optimal, and then you can stop at that point.
Okay, great. So we say that we have to keep it simple, probably because of high bleeding risk, that imaging is very useful. So most of us will try to do one stent. And interestingly, Dr. Rao already said that the circ looks really some haziness and really tight, meaning that we might probably end up with two stents. So maybe let's go back to Massy and see how Philippe and Bernard manage the next step.
Yes. So we select, as usual, the stent in reference to the distal diameter of the bifurcation. So it's here the proximal LAD. So 4.0 seems appropriate. Another point which is very important is to have enough stent in the main part of the bifurcation to have the room for doing the POT, because the POT is important, needs transforming this one stent with one diameter in one stent with two diameters in order to comply with the fractal law of coronary tree. Yes, in the meantime, the stent has been placed. At we have enough place to do the POT now. We can see that the circ is still open. It's still, I would say, a little bit better.
Right,
Before,
I agree, Bernard, actually. I was relieved after stent implantation. The circumflex actually improved, apparently, instead of deteriorating.
Yeah.
So you may have a point, actually.
And now we are going to do the pot. We have done the pot with 5.0. You can see if you have a pressure that the inflation in the left main are extremely poorly tolerated. Even very short inflation, we have a pressure decrease extremely rapidly, so we should be very, very fast, a little bit faster than we are usually.
Bernard?
But anyway, pressure is going up now.
Bernard, could you explain just the balloon positioning for the pot, you know, with the distal marker of the balloon regarding the carina, and because we were speaking too much
I think it's
during
important,
the pot.
of course. No, sorry, no problem. So I think we place the distal marker at the carina level, a little bit proximal to the carina. We don't go to be beyond.
So I have to say that there is a very important angulation between LAD and circumflex, and it's quite challenging to cross. I've tried to go in the LAD with a U shape in order to avoid to go even after pot to go under the strut, and then pull back and have the distal strut of the stent and reach finally the circumflex. So this one is now the circumflex. So this one is the jail wire. I think we can keep it for now. And Bernard, what do you think? We can go now for the kissing?
I think so. Yes, maybe we can go back to the area view, because this one is not
area view is better.
Very nice. What is important now is once you remove gel wires not to jump in the left main with a guided catheter and to get longitudinal compression. I think it's a very important tips and tricks for this part.
Okay.
So we have selected a 2.5 millimeter balloon for the circ, for the kiss, and a 4.0 for the LED, which is the nominal size of the stent we implanted.
Bernard, Philippe, we had also a question about the new strategy pot side pot, but you still only do kissing in the left main for the provisional approach?
Yes, we still use kissing, traditional kissing, because we think that it's not so easy to correct the distortion you create with the side opening. It's extremely easy to do that in bench test, but when you do that in real practice, you need to be sure that you are deep enough to correct the distortion, but not beyond the carina. So there is a margin which is extremely low, less than 1 millimeter, and the capability to do that in real life, in my opinion, is not very good.
Okay, meanwhile, I have to take my words back, because this ostium of the left main gets better and better.
Yeah, so the first step was so we had predilatation, then stent, then pot, and then kissing. We discussed pot side pot, but kissing was a good strategy. So now, Emanuele, here we are facing let's say the classical problem to have something tight with good flow on the ostium of the side branch. And what will be your strategy? You already discussed that a bit earlier, but looking at the angiographic result after the kissing, you will keep it simple, as mentioned earlier?
Yes, actually, you mentioned the fact that the flow is preserved. That is a very good indication that what you see at the angiogram might be misleading. You know, there was quite of an angulation. The colleagues have mentioned that. The simple presence of the guide wires might in itself provoke some ostial spasm, might even exaggerate the severity of the residual stenosis at the ostium of the circ. So I would not fully trust angiogram. And what we have here is the fact that OFDI is available. And I'm sure that OFDI, even if you don't insert the catheter towards the circ, something that I would try to do but again, without making too complex the procedure. But even if you just pull it back from LAD to the circ, you can see whether this pinching of the circ is truly related to a plug shift or not. But at this stage, I would not take any additional action, stick on the initial plan, go ahead, and then reevaluate at the end with OFDI.
Yeah, it's good that we have exactly a good question on that, Alaide, because people asking if you think the NGO is enough, or do you think in some case we need to do imaging as proposed by Emanuele, or even physiology to assess the osteom of the side branch in such bifurcation?
So in this specific patient, honestly, I would just stop as it is because of all the reasons we have been saying. I mean, my threshold to go from 1 to 2 stents in this case is not coming, and this is an high bleeding risk, and I agree that less stents we are implanting, the best it is. In case indeed of a younger patient, for example, with not all this kind of issue, I would do FFR, honestly. I mean, I think the anatomical data is not enough for the circumflex osteum, and I agree that most times these are pseudostenosis, and I do think of the added value of FFR to really evaluate if that pinching is functional, significant, and we really need to implant a second stent.
Okay, so we say here it's high bleeding risk patient, so we want to keep things very simple, but if not, we can help with imaging or physiology to decide whether we need to do more on the side branch. Bernard, we said earlier that we will try to make everything as simple as possible. Do you think in some case we can just do stent, left main LAD, pot, and if the flow is fine in a small circ, keeping in mind that we have also occluded first marginal, we can just put stent and pot without doing kissing? That was one of the suggestions that we had. Bernard?
Yes, of course, it's a possible option. I think in this patient with a multivessel disease and many recurrence of a coronary lesion, I would favor to keep the access and to be sure that the access to circ is still possible, even if the first worm is gone. We still have a runoff in the distal circ, so I would favor to keep the access to circ. I think this kind of strategy, which is just crossover plus pot, is good for non-left main bifurcation when the side branch is moderate size.
So you mean the circ is not a side branch as any others? It's a very special one.
This is why the left main is not it's a different animal.
Yeah, and maybe you can just make one word. You know, Bernard, we mentioned during the live, but it's between the kissing or the new pot side pot approach. You say that for the left main, it's probably safer still to do the regular kissing followed by pot or not.
Yes, I think when you open the strut, you create a distortion in the main part of the stent, and you have to correct this distortion. The best way to do that and to replace the strut at the right place is to do a kissing. You can achieve that with pot side pot in a bench test, but you need to know exactly where you are, and it's not always possible. It's not always possible to be sure that you are exactly at the carina, not too far, not too proximal. It's clearly possible to achieve a good result in bench test. I don't think that it's reproducible in human beings.
So it's a beautiful, challenging in bed test, but more challenging in daily practice in the cath lab.
Yeah.
You mean? So Emanuele, maybe the next point is we always say for bifurcation it's one stent or two stent. So it means that for the side it's balloon or drug-eluting stent. And we had Dr. Melen and Abdallah proposing a kind of compromise for the side branch between the balloon and the drug-eluting stent, which is obvious, the drug-eluting balloon. What is your view on that in this specific patient, for example, for the circ?
Well, In general terms, I don't like this strategy. If the side branch, and in this case the circumflex, needs something more than regular kissing balloon, then this something more for me would be a stent. I don't want to compromise much. But I take the challenge for this specific case. There might be some rationale in using drug-eluting balloon in a patient with distal left main bifurcation and high bleeding risk, because then you would prevent the use of an additional stent into the side branch. But again, EBC main has nicely shown that simply doing kissing balloon would reduce the recurrent revascularization without the use of drug-eluting balloon. So I would, again, not make any fancy reasoning, just keep it simple, kissing balloon, and that's it.
So we say that the flow in the circ is fine. We have a high bleeding risk patient. We have to keep it simple. So it's good that we reach the consensus that probably we can stop here. So let's see how Bernard and Philippe and the team in Massy managed the next step, or they just decided to keep it as it is.
Well, next step for us is to do the report, because we think that the report is important to avoid this bottleneck effect we have with kissing. I can see very, very well with OFDI, the bottleneck effect we create with kissing balloon. And we need to do a report, not too proximal. I think the most important thing is to be sure that you cover the very proximal strut. Usually, we really rely on the evaluation of the osteum. And if it's one of the added value of intravascular imaging, if the osteum is free of disease, if it's a very large osteum like we have here, I don't see any benefit to cover the osteum. I think I see even some drawback. First, the risk of malapposition, because we are dealing with very huge diameters. And the second drawback is the fact that if you do that, you increase the risk of longitudinal compression by the guiding catheter, because you are in a close contact with the first strut of the stent.
So this is a pullback from the distal part. I think maybe I will just skip a little bit. So there is some stenosis in the mid portion of the LAD. I think I will make one measurement here. It's a 1.88, so you can argue that this cutoff to predict the FFR positive is 2.0. So I think 1.8 could produce the ischemia after that. But I think most important findings is in the actually the proximal LAD part. You could see that there was a lot of malapose strut here. This is a proximal LAD. You can see the significant malapposition, which is extending around almost 270 degrees. So I think we definitely need to post-dilate here. And also, I think that there was under expansion of the stent around here. And now it's circumflex via is coming. So opening of the circumflex looks somewhat okay. And lumen is the, I think, still a little bit ellipsoid, but I think in the proximal part, especially, it is round and circular. Maybe let me check the expansion of the stent around just beyond the bifurcation carina. So it is 3.49, and I think reference diameter of the LAD was 5 millimeters. So I think we need to improve the proximal LAD stent.
Do you have stent boost or equivalent in this case to see if there is no under expansion of the stent, maybe on the lesion here?
Yes, I think we have a stent vis in this cath lab, of course. But I think we need to consider for malapposition detection, you need to inject contrast, because if you do only stent vis without contrast, you only detect under deployment of the stent, which is not the case. The case is fully deployed, but not at a good diameter.
Yes. So I think the malapposition was improved, but the quality of the image around the malapposition was not so optimal. I see the improvement of the expansion, apparently distal LAD. So this is the circumflex coming from the 7 o'clock. And just distal to this circumflex, I think we don't see the, despite the quality of the imaging, we don't see the significant malapposition, and it's really improved. And I think we can probably end the procedure, because I can make a measurement. Let me see the measurement.
So while we are doing measurements, this is the angiographic result running on the screen. I think, Bernard, we can say that we have treated this distal left main lesion with one stent. It was really challenging because of the anatomy. We had some aneurysm, big diameters, with the help of OFDI and a stent positioning and sizing according to intravascular imaging and good techniques with spot kissing with one stent. I think we have a good result for both branches.
Yeah, so I think it was really a great example of provisional strategy in true distal left main bifurcation in very complex high bleeding risk patient. So we had some questions. The first is more comment about it's nice that, Bernard, when we look at the NGO just before doing the OFDI, I think most of us will just have leave the cath lab saying that we did perfect job, and as very often we've seen a significant malapposition. So I think that could be a first take home, that really imaging can be really useful if we want to optimize, especially in a high bleeding risk patient, because if we want to stop DAPT after 1 or 3 months and leaving behind such malapposition, we know we might have a real problem. So Halaide, we had also question for this specific patient. On one side, you want to stop DAPT very early, but it's still distal left main and diffuse disease, multiple stents. What will be your DAPT strategy if it's your patient tomorrow in Milan?
Yeah, I mean, it's a good question, honestly. In case, so let's say, I would prolong if it's not needed to stop. I would say like that, because of the complexity of the patient. Honestly, if indeed there is the need to stop, I would not be afraid. I don't know if it's clear.
Yeah, you keep DAPT until the bleeding, more or less. That's more or less the philosophy.
No,
I will do the same, but I will do probably the same. Yeah, if the safety is fine, we want to keep longer. Bernard, what was the plan for this case?
So the plan was to try to keep DAPT for 3 months. I think it's a kind of compromise between the very short approach of 1 month. Of course, here we have stented the ostium to the right, we have stented the left main, even if it's a one stent strategy here. I think we want to keep at least 3 months if it's possible. Of course, if the patient has any bleeding event, we'll reduce to 1 month.
Yeah, that's the idea. So we had, again, a question asking if it's not HBR patient, we will do more. We discussed that earlier. Then probably we will treat the circ, we will do physiology or imaging to see if we have to do the circ. But of course, the HBR status of the patient was also a reason to try to keep all the procedure and the strategy simple. Emmanuel, we had just one question about the follow-up of these very challenging patients. He had a multiple PCI, stent in the distal left main, residual stenosis on the ostium of the circ. What will be your clinical follow-up for this specific patient? MRI again, as performed?
The nice part has already occurred. That was within the cath lab when we had a lot of fun. Now it becomes a bit more challenging because this is, as we like to call it, a frequent flyer patient, a patient that is used to come back and again, not just for the occurrence of instantary stenosis, but with rapid progression of coronary disease. What makes me thinking a lot in this patient is that 3 years before, this patient did not disclose any significant left main disease. And then this patient comes now again after 3 years with an important lesion in the left main. So that is amazing. In addition, we know from the last OCT pullback that there is already an LAD lesion in the mid-LAD that is almost mature to be treated. So this patient really needs to be closely followed up. What I would do personally is to see the patient first month after PCI, then every 6 months, listen to the patient clinically, but we know that this does not help a lot in terms of pain threshold. This is diabetic, renal failure, so I do not expect this patient complaining a lot. This is the typical patient that will refer some dyspnea, if not coming already with positive enzyme. That's a classic patient in our practice. And I would not target this patient with complex procedures like MRI. If I really need to do something, you know, nowadays CT has become nearly like a chest X-ray, and we know that FFR CT can improve the diagnostic accuracy in a stented segment. So now we can rely on CT also after stenting. Perhaps if I have to choose a more sophisticated test, I would do FFR CT with FFR CT at the follow-up.
Okay, thank you, Emanuele. So finally, when we are with good friends, good case, and good discussion, 60 minutes seems really too short. But it's time now to close the webinar by thanking, of course, first Bernard and the team in Massy for the beautiful recorded case. It was a perfect illustration of the management of HBR patient with complex PCI. Thanks, of course, to Halaide and Emanuele for the great lecture and discussion, and to all of you who really posted quite a lot of questions. That was a very good atmosphere that we have today, thanks to that. So, and of course, thanks to Medtronic who support this webinar. Of course, it will be on VOD on the PCR Online. And again, thank you very much and have a nice day. Thank you.